Thank you, James. So, my talk is on radiogenomics in paving the landscape of precision oncology. So, as I said, myself, Dr. Don Matthew, I'm an assistant professor at the Department of Biochemistry, Pacific Medical College and Hospital, Udaipur, Rajasthan. Next slide. So, radiogenomics is made up of two words. Next, please. Please play the whole slide. So, radiogenomics, as the name suggests, is made up of two words. One is radio, the other is genomics. So, radio stands for radiation therapy, which we give for cancer treatment. So, other than radiation, as we know, there is chemotherapy, there is ablation therapy, there is surgery, there is nowadays immunotherapy, and even gene therapies are in pipeline right now. And genomics, in the other end, the terms to the DNA sequence of a person, which is unique for an individual. So, radiation is one of the treatment modalities for cancer, and at least half of the cancer burden that we see all around globally, radiation therapy is one of the mainstay treatment which has to be included in the regime when planning for a complete treatment response. And among radiation therapy, also external beam radiotherapy, which is EBRT or teletherapy, is one of the most opted choice because it's comparatively less non-invasive, and it's easy to plan also, and especially in a developing nation like India, like mine, it's one of the most opted form of radiotherapy that is preferred for the patient. Other than that, we have brachytherapy, and with the technology advancements nowadays, we have new and emerging radiotherapy approaches like conformal radiation, IMRTs, which is intensity modulated radiotherapy, and image guided radiation therapies. Next slide, please. So the optimal radiotherapy schedule is always a ratio that we have to plan between how much of radiation has to be given. The dose is very important to achieve the BED, which is the biological equivalent dose, and we have to achieve the maximum cancer killing and minimal normal tissue damage that has to occur. So the total radiation dose and the dose per fraction and the number of fraction, overall treatment time, and the volume of the irradiation makes a big chunk of radiation planning as per se. So the point that it has to be planned, so how I've shown it in the arrow right now, the external beam radiation therapy is generally like a rectangular slit. So we just have a irradiation source which is cobalt 60. Just we open the slit, and the whole rectangle which has been planned around the tumor bulk or the tumor volume gets irradiated with the radiation beams. Next slide. But with conformal radiation, now we can have multi-leaf collimators, which, according to the tumor density and the cell volume, we can plan it around the contours of the tumor so that the normal tissue that is included in the radiation field is lesser. So the less the normal tissues are irradiated, the lesser will be the normal tissue reactions. So the lesser will be the side effects. So they are the advanced forms or the up and coming forms of radiation therapy, which is IMRTs and IGRTs, which includes MRI also along with the treatment planning. Next slide. And we have IMRTs, which is according to the dose volume, that according to the tumor burden, we can plan for intensity modulation around the tumor bulk. Yeah, next. Please play the whole slide. So we all know how radiation therapy works. It basically works with ionizing radiations, which generates free radicals or reactive oxygen species in the tissues, thus leading to breakage of the bonds, and the chemical bonds break down. And the most harmful effect that happens to the cell is damage of DNA. So the damage of DNA is the main reason. If it is not treated on time, or if the DNA repair mechanisms are not active on time, these damaged DNA will lead to the cell death, and the increased amount of cell death will lead to the death of the tissues. So how it helps us is that cancer being a rapidly dividing cells, the maximum amount of DNA damage happens to the radiation tissues. So the damage itself can be of further two types. It can be either a single stranded break or a double stranded break. And Around the ratio is around 400 single stranded breaks happen for every gray of radiation that is given to the tissue. So that further leads to a cell cycle arrest, which leads to activation of DNA repair mechanisms. If the mechanisms are active, the DNA damage is repaired and the cell will survive. But if there is a fault, as we'll see in the further slides, if there is a fault, the DNA damage mechanism is absent, it leads to further apoptosis, and even one double stranded break, if it is unrepaired, it will lead to instant tagging on for apoptosis. But if the DNA damage mechanisms like non-homologous end joining repair or homologous recombination repair, if these kind of mechanisms, BER, base excision repair, nucleotide excision repair, if these repair mechanisms are working properly, they will successfully repair the damage and the cell will be surviving. If not, it will be tagged on for apoptosis. So this radiation majorly affects the proliferating cells, which in our case is cancer cells. So we use radiation therapy in this module for treatment of cancer. So, as we saw in the previous slide, there is both killing of the cancer cell as well as the normal tissue which is involved in the field. So the external beam radiation, as I mentioned, in a developing nation, because it is cheaper, a cost-effective method, we send a major chunk of patients towards a cost-effective method like external beam radiation. But if conformal or IGRT was possible in a developed nation, and we would have sent all our patients to that method, but unfortunately, because we have to look at cutting effects, so we send our major chunk towards external beam, which is a rectangular shaped field. So the cancer killing happens both at the cancer cells and the normal tissue that is involved in the field. Next slide, please. So the side effects, as I mentioned, so whatever, be it cancer cells, be it normal cells, there will be a reaction happening. The cells will be dying, and accordingly, the body will react. So all patients potentially receive a curative therapy, and these patients will inadvertently having some or the other normal tissue toxicity, because the normal field, no matter even if we use IMRTs and IGRTs nowadays, still there will be some form of toxicity that is seen in every patient. So, depending on how much of the normal tissue was involved in the field, the severity will be between minor to severe, and the duration will become the instant effects which are shown are called as acute toxicities, and later on we'll be seeing them over a course of lifetime, which are called as late toxicities. So several grading systems are used for recording the radiotherapy side effects, like mild, moderate, severe. So accordingly, as I said, there are acute toxicities and late toxicities which happen. Acutes are the one which happen shortly or just after the completion of treatment. They are usually reversible in nature. When symptomatic treatment is given to the patients, the toxicity can be reversed. And rapidly proliferating tissues are the most affected ones which exhibit this acute toxicities. The severe acute toxicities, the mid treatment, the dosage has to be stopped or modulated, or the patient can also have an incomplete therapy, which further the radiation dose is given to the patient, but the patient has not properly responded back because of the toxicity. There is a treatment break. So the side effects are there in the patient, but the treatment efficacy will be just none or nil, because the proper dose that was supposed to be given is not given to the patient. So the other form of toxicity is late toxicity, which happens months to years after radiotherapy, and usually is a dose limiting factor. According to the dose that is given initially, the amount of late toxicity will vary. They are unfortunately a permanent kind of destruction, like obstruction of bowel or urethra following irradiation, or even like salivary glands getting affected. So there is xerostomia, or the tissues getting irritated so much that they generate fibrosis. So they are generally a permanent type of toxicity, and they negatively affect the quality of life that the patient is going to have post radiation. Next slide, please. Next slide. Please play the whole slide. So now, this is the most important slide on which I want to ponder on, and later on my slides will go on very fast. So now, where was the inherent problem? So let's say we have two patients. One is patient A, the other is patient B. Clinically looking, both of them are similar. The first patient is 52-year-old male patient with a 2 into 2 centimeter cancer on the right side of tongue. And the other patient is a 48, a nearly similar age male patient with a similar size, 1.5 to 1.8 centimeter cancer on the left side of tongue. Both of them, because they look similar to the radiation oncologist, we plan in the similar way, which is the conventional radical method, treatment with radical radiation, 2 gray per day in 30 sessions. And the same way, patient B is also planned. But now what we observe is that the patient A was able to well tolerate the therapy, the whole 2 gray per day, 30 sessions, that is 66 gray that was planned in the patient. He tolerated it very nicely and there was a very good remission. The acute toxicity grade never went above grade 2 CTCAE, and the toxicity grades were also less, and the tumor killing was done properly, and patient survived. But in the other patient, there was a severe degree of mucositis just after 3 weeks of treatment, so much severe that we had to give a treatment break, a feeding tube had to be inserted, and we had to force stop the radiation therapy just after 3 weeks. So now you can see there was a 30 session day that was planned, a 4 week schedule was planned. But in the third week itself, we had to stop the treatment. So the biological effective dose that was required to kill the whole tumor cells could not be given to the patient. So what happened here? Please play next slides. So what went wrong with the patient? Can we do something? And can we predict the toxicity that the patient is supposed to have depending on the genetic signature of the patient? So herein comes the whole hypothesis of my study. If we can predict or propose a conformal IMRT IGRT treatment for patient like B, who we know beforehand is not going to survive the conventional radical method, but instead needs a much more controlled or conformed form of treatment wherein only the tumor irradiated region has to be irradiated and the normal tissue has to be spared, because the patient is going to inadvertently have a very high form of toxicity. So can there be a prediction model or a prediction statistics which could bring in such a segregating factor wherein a patient B could be sent to higher form of radiation while patient A could be taken in for a normal conventional radical method? So this was the whole idea or the whole hypothesis of my study. Next slide, please. So can we predict whether a patient is susceptible to increased normal tissue reactions during radiotherapy? And can this genetic profiling of an individual be used to predict radiation toxicity? So our goal was to develop a mathematical predictive model wherein the input would be the different parameters of genetic profiling like single nucleotide polymorphisms, especially of the DNA repair, radiation fibrogenesis, and oxidative xenobiotic metabolism pathways, and the clinical parameters of this patient, the patient which inherently carries with him, like the Karnofsky performance scale, the general condition of the patient, the stage at which the patient is being presented, whether it's a stage 3, stage 4, the grade of the disease, the tumor size, the TNM staging, the pathological staging, whether the patient had any predispositions like smoking history, tobacco chewing history, and all of these parameters inputting into a predictive model and finally churning out a probability of the type of toxicity the patient is going to exhibit later on. So based on the risk score that we are getting, can we segregate the high risk patient towards a more advanced form of therapy, and the other side, could we take the other side of a normal person, a less risk, a lower risk patient towards the conventional radical method? Next slide, please. So the rationale behind was, can we have conformal radiation, IMRT, IGRT for all patients? No, we are a developing nation and it's only available in the higher centers and developing country like India. It has very high cost and less number of patients can be treated, and our patient burden is too high. And successful development of such a model will radically change the approach towards conventional radiotherapy. Next slide. So there were few association studies, as you can see. So there are the different studies. Just play through the whole slides. So they were just association studies which were seen, and they were not actually having any predictive power in them to clearly say that whether these polymorphisms, if predicted beforehand, could have any prediction towards the radio response of the patient. Please play through the whole slide, and then the next slide. Right. Next slide. Next slide, please. Next slide. Right. So we had to go through our whole literature. So this was one of our major studies that we had honed in on to pick up our candidates. So we picked up few candidate genetic markers to develop a panel of polymorphisms to check it across our whole population, and which were already reported in previous studies for acute and late toxicities. So these are the few candidates that we had picked up: XRCC5, XRCC3, XRCC1, ERCC4, TGF1, RAD51, ATM gene. So these were the few polymorphisms that we had picked up. Next slide. So our whole study was planned in two phases because it was a initial kind of a clinical trial that we were trying to do, or developing a model and then segregating the patients. So we had to follow proper guidelines. So our study was registered under the Ethical Clinical Trial Registry of India, CTRI, and a proper clinical trial of phase 1 and phase 2 was planned. The part 1 was development, wherein we recruited 200 head neck squamous cell carcinoma patients. Now, please bear in mind, when I say 200 HNSCC, we made sure they were HNSCC. Only the squamous cell type was taken forward. The basaloid types, or the less differentiated, or the keratinizing type, or any other subtype which was different from squamous cell was avoided. I would ask why? Because the initial prediction model, the bias has to be minimum in the beginning itself, so that the way that we develop our model is very precise and very accurate. So later on, we can bring in all the other forms of treatment modality also. But for the initial stage, when we are developing our model, our bias has to be as minimal as possible. So we honed in on head neck cancer patients who were of this common cell type, and all of them were clearly following the conventional 2D radical radiation method. So any form of C boost, any form of concomitant chemotherapy, any form of surgery, prior surgery, or neoadjuvant therapy, any form of altering therapies were completely removed, and all the patients were clearly at baseline. They were all similar to each other in age and gender matched form. So they were further documented for their acute and radiation toxicities incurred in them according to the CTCA and RDOG criteria. And further, we analyzed a few polymorphisms in these genes of DNA repair pathway, radiation fibrogenesis pathway, and oxidative metabolism pathway, and developed a risk analysis model. So this was the developing phase. Now we had to validate them. So we recruit a whole separate cohort of biopsy proven new cases of HNSCC. They were again clinically evaluated with the risk ratio that was developed with the model. Then the genetic markup was seen, and we gave them higher risk and lower risk categories, and they were sent to either modalities, and we saw how much was our prediction power on basis of our validation phase. Next slide. So the modality that we utilized was a Bayesian hierarchical modeling strategy, wherein our end goal was the toxicity status, and three kinds of variables were incorporated into it. Please play the whole slide. So the first kind of variables that we incorporated were the primary variates, which were the polymorphisms that were analyzed. The second kind of variations were the prior covariates, which the patient carried with himself, which was the age of the patient. If it was an older age patient, it's but natural to tolerate it lesser as compared to a younger age patient who has much more DNA repair mechanisms. And the general condition of the patients, if he was not having a proper GC less than 70 kps and all, they were kept as a higher risk, while a better GC, a better kps of 90 and above was kept as a protective factor. Smoking history of the patient, the tobacco chewing history of the patient, alcohol intake history, family history of any malignancies before. So they were all kept in prior covariates, and we also included some fixed covariates which were part of the treatment planning strategies, which were TNM staging of the patient, the histology of the patient, the time that the toxicity was appearing, the weight loss that was incurred during the total treatment time, and whether some Riles tube insertion, etc., was needed and all. And along with this, we also checked few prior gene to gene connections, because there can be haplotypes. There can be some genes interacting with each other, and they could be having a confounding effect. Maybe one pathway is inhibiting the other, or maybe one pathway is activating the other. So there could have been any kind of prior gene to gene connections. So all these 16 polymorphisms that we included, we also looked for prior gene connections, and they were also included as an increased bias. And all these four parameters further churned out our probability in form of a toxicity status of lesser toxicity, which is grade 1 to 2. So in our Indian setting, till the acute toxicity is between grade 1 and 2, the patient is allowed to have this full treatment. If grade 3 is achieved in any of the toxicities, let's say mucositis, dermatitis, dysphagia, any toxicity touching grade 3, the treatment break has to be given. So treatment break is our point where we have to take the patient out of the study or send it to a higher risk. So that was kept as our risk factor. And grade 3 versus grade 1 and 2, the toxicity status was checked on basis of these four strategies, and one by one these variables were included for our hierarchical modeling strategy. Next slide, please. So the methodology that we opted, we did an initial association check based on chi-square Fisher exact, and then we did a correlation analysis to check for odds ratio and 95% confidence interval. Then further, these two strategies were taken forward, one into regression modeling strategy and the other to prediction modeling. In regression modeling, we undertook multivariable regression modeling to see the cumulative effect of these toxicities, and then to see the time to event effect of these polymorphisms, we utilize Cox proportional regression. In predictive modeling, for the first time, we incorporated decision tree based modeling, which was CART modeling in our study, and we also included random forest model to see whether the reproducibility of the CART model could be validated in our model. So we utilized both the regression and predictive model to generate our high risk and protective low risk pattern of our toxicities. Next slide, please. So for mucositis modeling, 16 polymorphisms were selected, initial association check was done, and polymorphism XRCC1, ERCC4, HDM2 polymorphism, along with KPS, tobacco chewing history of the patient, and the weight loss happening in the patient, had a very high risk of predicting an association with high grade of mucositis. Next slide, please. Further, they were taken to univariate analysis to check for both confidence interval and the odds ratio. And every polymorphism were further subdivided into code 0, low risk and baseline group, and code 1 as high risk group on basis of the kind of polymorphism pattern that the patients were carrying. So in the first type of group, we wanted to see whether the allele, which is the dominant type, in both its homozygous and heterozygous form as compared to the variant allele in its homozygous type is having an effect. The second type of coding for the same polymorphism was done whether the variant allele and the recessive allele in its heterozygous as well as the homozygous type is having a risk towards the wild type allele. So both of these studies had to be done because these polymorphism was being studied in an Indian scenario for the first time. So there was no clear frequency paradigm that was available for us to see which type of allele was actually the risk allele involved in our study. So we undertook both kind of coding as seen here as an example for XRCC1. So there was both kind of coding wherein both the variant allele and the dominant recessive and the dominant allele were given separate codings and were taken forward for binary logistic regression. And this was done for all 16 polymorphisms, by the way. And then the BLR gave us our significance levels and exponents and odds ratio level, and only the significant parameters further went to both regression as well as prediction modeling. Next slide, please. So they went for multivariable regression model and patients were grouped together as earlier, and the risk of prediction of grade 3 of mucositis was checked here. Next slide. So for our mucositis model, backward stepwise elimination method was used, and SNP1, which was XRCC1 homozygous GG, that is our homozygous dominant and heterozygous form, was seen to have a protective effect, and the variant allele in its homozygous form had a very high significance towards prediction of high grade of mucositis, which was the odds ratio was 2.2, and accordingly there was also two variables which were tobacco chewing history and KPS 70 predicting towards high grade of mucositis. Next slide, please. Further, a time to event analysis was done, and here the time was taken at 3 different stages. There was a therapy start day, the first appearance of grade 1 of mucositis, then the time of grade 2 of appearance of mucositis, and time of grade 3 appearance of mucositis, and grade 3 was the point where we had to stop our study. So that was our cut point, and there were three different type of time points available for our model, and accordingly we did our Cox regression study. We found that tobacco chewing history of the patient and lower kps 70 had a very significant effect towards development of high grade of mucositis. Next slide, please. We further took predictive modeling, which was classification and regression tree, CART modeling, which is a decision tree based modeling strategy. And we utilized Salford predictive model version 8. The variables were input in two codes now. So the decision tree basically stratifies and categorizes the data on basis of chunks of the type of questions we are asking. So the initial tree node will ask a question, whether this condition holds true or not. Then accordingly, the data is stratified into a yes and no form. And as we try to stratify the data, each time a significance is checked. If the significance level holds on, then it moves to the next slide. And accordingly, we find a chunk of data which is having the maximum probability or the maximum chunk of data answering all the subset of answers. And that becomes a predictive trend for that particular node. So data was stratified in descending order according to the most significant predictive variables for the outcome, which was grade 3 of mucositis. So in CART model, the additional benefit as compared to the easy initial regression model is that there is a way of having self-validation in our study. That means if we have 100% data, so we can take a chunk out of the data and ask it to run a separate CART model, let's say a separate test data and a learned data. So we can check for whether the probability holds true across both the data sets or not. So the power of self-validation actually gives us a much more stronger form of probability ratios, wherein we could test in itself our model whether it is holding true or not, as compared to the later on validation study, a phase 2 study which we did later on. Next slide, please. So you can see in the CART model, we had these node characteristics wherein the first question asked was whether HDM2 homo-TT genotype present or not. Tobacco chewing history was absent. XRCC1 homo-GG, which is the dominant homozygous allele, so homo-GG genotype, and a higher KPS of the patient, which is KPS 90 and 80. So in the arrow, you can see a terminal node that is shown. So the patients in that particular node had 85% chance of a low probability or a protective nature towards grade 3 mucositis. So the model that we developed had a sensitivity of 82% and a specificity of 73%. Our ROC was 0.687. Next slide, please. We also did random forest model because the way that the data chunk is done, so there can be bias that is created in our statistical model. So we incorporated random forest into our study. Random forest is multiple CART trees being run in the earlier way, and that whole chunk of data is cross-checked upon itself for the reproduction efficacy of the pattern that is observed. And the biasing that is generated by this random partitioning is reduced because the number of times the CART model is run, the data is being reproduced again and again and cross-validated on itself. So we can find whether the probability ratio actually holds true or not. So the optimal number of trees that it has to be run was decided by stochastic grading using treenet map. And again, there was learn versus test data and self-validation that was involved. Please, the next slide. So the variable reproducibility of the CART parameters were checked. So tobacco chewing history had the highest reproduction efficacy of 72%, showing that the tobacco chewing has really got a very big effect on development of mucositis, be it in a tobacco chewing history was showing appearance of toxicity grade 3, and the absence of the tobacco chewing history was also having a protective effect. So the lifestyle habit of tobacco chewing really has a very high chance of how a toxicity pattern will be seen in a patient. Along with that, HDM2 polymorphism, a higher KPS, and XRCC1 homozygous dominant allele was seen to have the highest protective effect. Next slide, please. So this was the risk prediction model for mucositis, wherein high-grade mucositis and low-grade mucositis model was developed based on the regression and the prediction modeling strategy. XRCC1 in its wild type was having a protective effect, while the recessive allele type, variant allele type was having a deteriorative effect. Tobacco chewing history was very important factor, showing that it is having a history of tobacco chewing is having a deteriorative effect towards a higher grade of mucositis being achieved very quickly, and a lower KPS of the patient also had a very worsening effect after 30 to 35 gray of radiation dose being given to the patient. So now we can see here we are able to clearly segregate a HNSCC patient on based of his genetic profiling and his lifestyle habits that he's carrying with him to actually segregate the patient towards a protective effect and a deteriorative effect. So the patient having these three parameters showing at the OPD, a radiation oncologist now clearly says, okay, this patient is not suitable for a conventional radical radiation. You have to take him for IMRTs and IGRTs because these three prediction factors are clearly indicating that the patient will inherently have a higher grade of mucositis as compared to his normal looking counterpart. So now this was the whole study that we were trying to pinpoint and segregate out a patient who was having a higher risk towards development of a higher grade of toxicity. Next slides, please. So just like mucositis, we also developed a model for dysphagia. So in dysphagia, a female gender patient with an XRCC6 polymorphism, KPS, lower KPS, tobacco chewing history, and hemoglobin levels less than 15 were having a deteriorative effect, and their counterparts on the other hand were having a protective effect. So again we can see a predictive pattern where we can pick out patients who have a very high chance of having dysphagia after conventional radical radiation. Next slides, please. We also developed one for xerostomia. So here also we could see the weight loss incurred in the patient, the appearance of the acute toxicity, polymorphisms of XRCC1, ERCC4, and if there was a treatment break given to the patient along with RAD51 polymorphism in this combination were very deteriorative towards the patient developing a late toxicity of xerostomia, while on the other hand the protective pattern could be seen. So easily a patient could be of these parameters could be segregated to have a lesser grade of mucositis and sent to IMRTs or IGRTs instead of conventional radical radiation. Next slide, please. Similarly, we also developed one model for subcutaneous fibrosis. We could see a bigger T stage, tobacco chewing history, XRCC5 and TGF-beta1 polymorphism had a worsening effect after 5 months for development towards subcutaneous fibrosis. Next slides, please. So this was our group. Dr. Sushmita Ghoshal was professor and head of the department of radiotherapy. Dr. Arnab Pal, professor, department of biochemistry. Dr. Ankita, who was the clinician available with me, her thesis was part of the study, and myself, Dr. Don Matthew, I was an assistant professor at Department of Biochemistry. So this was a whole study where we developed these prediction models to actually pick and choose a patient from a normal looking pattern. And for a radiation oncologist, based on his theoretical knowledge, he'll never be able to predict which kind of patient is going to really behave in which sense and which patient will have a very high chance of toxicity. So this study was the pioneer, and right now it's being taken up for our internal trial phase 4. We developed the first 2 phases as part of our initial study. Now our studies have been showing very promising results in phase 4, and soon we'll be publishing our work, and then I'll be able to present it further. And along with head neck cancers, now we have moved on to cervical cancers also, and we are also trying to look at radiogenomic models for breast cancers, which is another kind of a very big burden in India. The highest female mortality happens in cancer due to breast cancer, and in males in lung cancer. So we are taking up these radiogenomic models for these further 3 types of subcancers, which is lung cancer, cervical cancer, and breast cancer also. So thank you for your patient listening, and thank you all. Thank you so much.